Good morning. Normal puerperium. Puerperium is a Latin word which means child bringing forth. The definition is time following delivery during which pregnancy induced maternal, anatomical and physiological changes return to non-pregnant state. The retrogressive changes are mostly confined to the reproductive organs with exception of the mammary glands which in fact show features of activity. Involution is the process whereby the genital organs revert back approximately to the state as they were before pregnancy. The woman is termed as puerpera. Duration: it begins as soon as the placenta is expelled and lasts for approximately 6 weeks when the uterus becomes regressed and almost to the non-pregnant size. The period is divided into immediate, which is within 24 hours, early is up to 7 days and remote up to 6 weeks. Similar changes occur following an abortion but takes a shorter period for the involution to complete. In involution, we have two considerations, anatomical and physiological. In anatomy, it is uterus involving lower uterine segment and cervix. Physiology, muscles, blood vessels and endometrium. So the uterus, immediately following delivery, it becomes firm and retracted with alternate hardening and softening. The uterus measures about 20 into 12 into 7.5 centimeters and it weighs about 1000 grams. At the end of 6 weeks, the measurement is similar to that of the non-pregnant state and it weighs just 60 grams. The placental side contracts rapidly, presenting a raised surface which measures almost 7.5 centimeters and it remains elevated even at 6 weeks when it measures about 1.5 centimeters. The cervix contracts slowly. External os admits 2 fingers for few days, but by the end of first week, it narrows down to admit just the tip of finger. The contour of the cervix takes longer time to remain, but the external os, as you can see in the picture, it never reverts back to the nulliparous state. A is the nulliparous cervix and B is after pregnancy. Physiological consideration. Muscles, there is marked hypertrophy and hyperplasia during pregnancy and the individual muscle fiber enlarges to the extent of 10 times in length and 5 times in breadth. During puerperium, the number of muscle fibers is not decreased, but there is just decrease in the size of the myometrial cell. Withdrawal of the hormones estrogen and progesterone will lead to increase in activity of uterine collagenase and release of the proteolytic enzyme. Autolysis of the protoplasm will occur by this proteolytic enzyme. That's why these proteins are excreted through kidneys as urea and creatinine. This explains the increased excretion of the products in the puerperal urine. The connective tissues also undergo the same type of degeneration. The conditions which favor involution are efficacy of the enzymatic action, relative anoxia induced by the effective contraction and retraction of the uterus. Blood vessels. The changes of the blood vessels are pronounced at the placental site. The arteries are constricted by the contraction of its wall and thickening of the intima, followed by thrombosis. During the first week, the arteries undergo thrombosis, hyalinization and fibrinoid end arteritis. Veins in a similar way are obliterated by thrombosis, hyalinization and endophlebitis. Endometrial changes. Superficial layer of the decidua basalis becomes necrotic and it is sloughed in lochia. Basal layer, which is adjacent to the myometrium, that remains intact and this is the source of new endometrium. New endometrium arises from the proliferation of the endometrial glandular remnants and stroma of the interglandular connective tissue. So, just the superficial layer of decidua basalis is sloughed. This regeneration starts by 7th day. It occurs from the epithelium of the uterine gland mouths and interglandular stromal cells. Regeneration of the epithelium is completed by 10th day and entire endometrium is restored by 16th day except at the placental site where it takes about 6 weeks. Clinical assessment of involution of the uterus. The rate of involution can be assessed clinically by noting the height of the fundus of uterus in relation to the symphysis pubis. This measurement should be taken at a fixed time every day by the same observer. When we are doing the measurement, the bladder must be emptied, preferably the bowel too, because the full bladder or loaded bowel will raise the level of the fundus of uterus. Uterus is to be centralized with a measuring tape and the fundal height is measured above the symphysis pubis. Following delivery, the fundus lies about 13.5 centimeters above symphysis pubis. During the first 24 hours, the level is constant. Thereafter, every day it decreases by 1.25 centimeter, so that by the end of second week, the uterus becomes a pelvic organ. This is the picture showing how do we examine the height of the fundus from the symphysis pubis. So the fundal height at delivery is 13.5 centimeters above the symphysis pubis, and by almost day 9 it is going to become a pelvic organ. Involution of other pelvic structures. The distensible vagina noticed soon after birth takes a long time to involute. It regains its tone but never to the virginal state. Mucosa remains delicate for the first few weeks and submucous venous condition persists even longer. Rugae partially reappear at the third week but never to the same degree as in pre-pregnant state. Hymen is lacerated. Broad ligament require considerable time to recover from the stretching and laxation. Pelvic floor and pelvic fascia take even longer time to involute from the stretching effect during the parturition. Lochia. It is the vaginal discharge for the first fortnight during puerperium. Discharge originates from the body of the uterus, cervix and vagina. The odor is offensive fishy and it is alkaline in nature, which tends to become acidic towards the end. What does lochia contain? RBC, shredded decidua, epithelial cells, bacteria, vernix caseosa, lamigo. Color of the lochia. Lochia rubra, which is red colored, is just up to 3 days. Mainly it consists of RBC. From day 4 to day 9, it is lochia serosa, which is pale color, consists of WBC, mucus and wound exudate. And the last day to 15, lochia alba, day 10 to day 15, it consists of leukocytes and less fluid content. Average amount of discharge for the first 5 to 6 days is estimated to be 250 ml. Normal duration of lochia may extend up to 3 weeks. Clinical aspects. If the red lochia is persistent, there may be subinvolution. If the lochia is offensive and excessive, infection, scanty or absent, it is lochiometra. Persistent beyond 3 weeks, it is genital lesion. This is the sanitary pad which is showing the amount of lochia. Scant is just a 2-inch stain, small is 4-inch, moderate is 6-inch and large is more than 6-inch stain, which shows 50 to 80 ml of lochia rubra. What are the other general physiological changes which occur in a puerperial woman? Pulse. For the first few hours after normal delivery, the pulse rate is likely to be raised, which will settle down to normal during the second day. Temperature should not be above 37.2 degrees Celsius within the first 24 hours. There may be slight rise following delivery, but it comes down to normal within 12 hours. On the third day, there may be slight rise of temperature due to breast engorgement, but it will not last for more than 24 hours. But if it is lasting, genitourinary tract infection should be ruled out. The bladder mucosa becomes edematous, often shows evidence of submucous extravasation of blood. The capacity is increased, it may be over-distended without any desire to pass urine. The common urinary problems are over-distension, incomplete emptying and presence of residual urine. Urinary stasis is seen more than in 50% of women. The risk of urinary tract infection is therefore high. GI tract. Increased thirst in early puerperium is due to loss of fluid during labor in the lochia, diuresis and perspiration. Constipation is common problem for the following reasons: delayed GI motility, mild ileus following delivery, together with perineal discomfort. Some even have problem of anal incontinence. In addition to the weight loss as a consequence of expulsion of the fetus, placenta, liquor and blood loss, a further loss of about 2 kg will occur during puerperium, chiefly which is caused by diuresis. The weight loss may continue up to 6 months of delivery. Fluid loss. There is a net fluid loss of at least 2 liters during the first week and an additional 1.5 liter during the next 5 weeks. The amount of loss depends on the amount retained during pregnancy, dehydration during labor and blood loss during the delivery. All these factors will influence the fluid loss. The loss of salt and water are larger in women with preeclampsia and eclampsia. Blood values. Immediately following delivery, there is slight decrease of volume of blood due to blood loss and dehydration. It returns to non-pregnant state by second week. Cardiac output rises soon after delivery to about 80% above the pre-labor value, but slowly it returns to normal within 1 week. RBC volume and hematocrit return to normal by 8 weeks postpartum. Leukocytosis to the extent of 25,000 occurs following delivery, probably in response to the stress of labor. Platelet count first decreases after the separation of placenta, but secondary elevation will occur with increase in platelet adhesiveness between 4 to 10 days. Fibrinogen remains high up to the second week of puerperium. A hypercoagulable state persists for 2 days postpartum, and fibrinolytic activity is enhanced in the first 4 days. The secondary increase in fibrinogen factor 8 and platelets in the first week increases the risk for thrombosis. The increase in fibrinolytic activity acts as a protective mechanism. The onset of first menstrual period following delivery is very variable, and it will depend on the lactation. If a woman does not breastfeed, then the menstruation mostly returns by 6th week in 40% and 12th week in 80% of cases. In the non-lactating mothers, ovulation may occur as early as 4 weeks, and in lactating about 10 weeks after delivery. A woman who is exclusively breastfeeding, the contraceptive protection is about 90% up to the 6 months of postpartum. Thus, it is a natural method of contraception. Non-lactating mother should use contraceptive measures in 3rd postpartum week, and the lactating mother in the 3rd postpartum month. So why is there amenorrhea and anovulation in lactating mothers? In lactating mothers, there is increase in serum prolactin level to more than 50 nanograms per milliliter. As a result, ovarian response to follicle stimulating hormone is inhibited, so there is less follicular growth, hypoestrogenic state, and that's why no menstruation. Similarly, there is anovulation because LH release is suppressed, there is no LH surge, so anovulation. Next is lactation. For the first 2 days following delivery, no further anatomical changes in the breast occur. The secretion called as colostrum, which starts during pregnancy, this becomes more abundant during the puerperial period. Physiology of lactation. The physiological basis of lactation is divided into 4 phases. They are mammogenesis, which is preparation of breast, lactogenesis, synthesis and secretion from the alveoli, galactokinesis, which is ejection of milk, and galactopoiesis, which is maintenance of lactation. A healthy mother generally produces 500 to 800 ml of milk in a day to feed her infant. This requires extra 700 kilocalories per day for the mother, which must be made from the diet or from her body store. For this purpose, a store of about 5 kg of fat during pregnancy is essential to make up any nutritional deficit which occurs during lactation. Stimulation of lactation. Mother is motivated as regard the benefits of breastfeeding since the early pregnancy. No prelacteal feeds are given to the infant. What are the important steps following delivery for lactation? The baby must be kept to the breast of the mother at 2 to 3 hours interval from the day 1 itself. Mother is supposed to be given plenty of fluids to drink, and breast engorgement is supposed to be avoided. Early and exclusive breastfeeding in the correct position are encouraged. Okay, now let us come to management of normal puerperium. What are the principles in the management? To restore the health of the mother, to prevent infection, care of the breast including promotion of breastfeeding, and to motivate the mother for contraception. These 4 principles are important. Immediately following delivery, what is the attention required for the mother? Check vitals, uterus fundal height, any active bleeding, PV. BP and pulse are to be taken every 15 minutes for the first 2 hours, or more frequently if any indication is there. Temperature should be assessed every 4 hours for the first 8 hours, and then at least every 8 hours. This is according to ACOG 2009. Emotional support is essential. Usually the first feeling of mother is sense of happiness and relief with the birth of a healthy baby. The woman needs emotional support when she suffers from postpartum blues or stress due to newborn's prematurity, any illness or congenital malformation or death. Rest and ambulance. Early ambulation after delivery is beneficial. It provides a sense of well-being. Bladder complication and constipation will be less. It facilitates uterine drainage and hastens involution, lessens puerperal venous thrombosis and embolism. Hospital stay. Early discharge from the hospital is an important universal procedure. Most women are discharged fit and healthy after 2 days of spontaneous vaginal delivery and 96 hours after uncomplicated LCS with proper education and instructions. Some may need prolonged hospitalization due to morbidities such as urinary tract infection, perineal wound, gaping, pain, breastfeeding problems. The patient should be on normal diet of her choice. If the patient is lactating, high calories, adequate protein, fat, plenty of fluids, minerals and vitamins should be given. However, in non-lactating mothers, a diet as in a non-pregnant is enough. Care of the bladder. The patient is encouraged to pass urine following delivery as soon as convenient. At times, the patient may fail to pass the urine and the causes may be unaccustomed position, reflex pain from the perineal injury. This is common after difficult labor or a forceps delivery. If patient still fails to pass urine, then catheterization should be done. Care of the bowel. The problem of constipation is much less because of early ambulation and liberalization of the dietary intake. Sleep. The patient is in need of rest, both physical and mental. She should be protected against worries and undue. Sleep is ensured providing adequate physical and emotional support. If there is any discomfort or pain, they should be dealt with adequate analgesics. Care of the vulva and episiotomy wound. Shortly after delivery, the vulva and buttocks are washed with soap water down over the anus and a sterile pad is applied. Patient should look after personal cleanliness of the vulval region. The perineal wound should be dressed with spirit and antiseptic powder after each act of micturition and defecation or at least twice a day. The nurse should use sterilized gloves during the dressing. Cold baths will relieve pain. When the perineal pain is persistent, a vaginal and rectal examination is done to detect any hematoma, wound gaping or infection. For pain, ibuprofen is safe for nursing mothers. Care of the breast. The nipple should be washed with sterile water before each feeding. It should be cleaned and kept dry after the feeding is over. A nursing brassiere provides comfortable support. Nipple soreness is avoided by frequent short feedings rather than prolonged feeding, keeping the nipple clear and dry. Candida infection may be another cause. Nipple confusion is the situation where the infant accepts the artificial nipple but refuses the mother's nipple. This is avoided by making the mother's nipple more protractile and not offering any other supplemental feeds to the infant. Maternal-infant bonding, it is known as rooming. It starts from the few moments after birth. The baby should be kept in her bed or in a cot beside the mother's bed. This will not only establish the mother-child relationship, but the mother is conversant with the art of baby care so that she can take full care of the baby while she is at home. Baby-friendly hospital initiative provides parent-infant bonding, baby rooming with the mother, and breastfeeding. Immunization. Administration of anti-D gamma globulin to the unimmunized Rh negative mother bearing Rh positive baby. Women who are susceptible to rubella can be vaccinated safely with attenuated rubella virus. Mandatory postponement of pregnancy for at least 2 months following vaccination can be easily achieved. The booster dose of tetanus toxoid should be given at the time of discharge if it is not given during pregnancy. Management of small ailments. After pain. What is after pain? It is the infrequent spasmodic pain which is felt in the lower abdomen after delivery for a variable period of 2 to 4 days. The treatment includes massaging the uterus with expulsion of the clot followed by administration of analgesics and antispasmodics. Pain on the perineum. As we have discussed earlier, never forget to examine the perineum. Early detection of vulvovaginal hematoma can be made and SIDS bath will give relief. Correction of anemia. Majority of women will remain in anemic state following delivery, so supplementary iron therapy is to be given for a minimum period of 4 to 6 weeks. Hypertension is to be treated until it comes to normal. Physician should be consulted if proteinuria persists. A chart is supposed to be maintained, noting the pulse, respiration, temperature, recording 6 hourly or at least twice a day. Measurement of the height of the uterus above symphysis pubis once a day in a fixed time with prior evacuation of bladder and bowel. Character of lochia, urination and bowel movement. Swati. This is the chart which we were discussing, which notes the important clinical events in the puerperium. Okay, postpartum exercise. Postpartum exercise, the main objectives are to improve the muscle tone which are stretched during pregnancy and labor, especially the abdominal and perineal muscles. To educate about correct posture which is to be attained when the patient is getting up from her bed. This also includes the correct principle of lifting and working positions during the day-to-day activities. Why do we need to do the postpartum exercises? The advantages will be to minimize the risk of puerperial venous thrombosis by promoting arterial circulation and preventing venous stasis, preventing the backache, and to prevent genital prolapse and stress incontinence of urine. So postpartum exercises must be encouraged. Physical activity should be resumed without delay. Sexual activity may be resumed after 6 weeks when the perineum is comfortable and bleeding has stopped. A thorough checkup of the mother and baby is mandatory prior to the discharge of the patient from the hospital. The discharge certificate should have all the important details as regard to the mother and baby. What is the advice you give to them on discharge? Advices include measures to improve her general health, continuation of supplementary iron therapy, postnatal exercises, procedure for a gradual return to day-to-day activity, breastfeeding and care of the newborn, avoidance of intercourse for a reasonable period of 4 to 6 weeks until laceration or episiotomy is healed, family planning advice and guidance. Non-lactating mothers should practice some form of contraceptive measure after 3 weeks and lactating, as we have discussed, after 3 months of delivery. In lactating women, progesterone only pill may be a better choice. Other progestins, DMPI, levonorgestrel may be used. IUDs are also satisfactory irrespective of breastfeeding status. Sterilization is suitable for those who have completed their families. Postnatal care. Postnatal care includes systematic examination of the mother and baby and appropriate advice given to the mother during the postpartum period. The first postnatal examination is done and the advice is given on discharge of the patient from the hospital. The second postnatal examination and care will be conducted at the end of 6th week postpartum. So examination of the mother when she comes back includes routine examination of weight, pallor, blood pressure, tone of the abdominal muscles, examination of the breast. Pelvic should be done only when indicated. Following should be noted. A cervical smear may be taken for exfoliative cytological examination if it has not been done previously, and if she is desiring for any contraception, IUD may be kept in when desired. Laboratory investigations depending on the clinical need. If she is pale, hemoglobin can be advised. Examination of the baby is to be conducted by a pediatrician. In this respect, attached well baby clinic to the postpartum unit is necessary. The progress of the baby is evaluated and preventive or curative steps are to be taken. Immunization to the baby is started. Advices generally which are given: patient is sound health, she is allowed to do her usual duties. Postpartum may be continued for another 4 to 6 weeks. Evaluate the progress of the baby periodically and continue breastfeeding for 6 months. Family planning, counseling and guidance. A good method to remember all the management of the postnatal care is the use of the acronym BUBBLERS, which be for breast, uterus, bladder, bowel, lochia, episiotomy wound, emotional response and Homan sign. So these are the things which are supposed to be checked in a postnatal patient. Homan sign is for the dorsiflexion of the foot, which we check for deep vein thrombosis. Thank you.